Hi everyone, my name is Faye Missar. I started in the MPH program in 2013. Kelsa, she's the only other one. So I'm here to speak today about an idea I have for a pilot program on the west coast of Vancouver Island called the West Coast Fruit and Vegetable Prescription Program. And I did my practicum with the the Long Beach chapter of the Rural and Remote Divisions of Family Practice. So thank you to my practicum supervisor, Dr. Carrie Marshall. Before we dive in, I'd just like to thank and acknowledge Cloquet First Nation and Nucleothat for hosting me as a practicum student on your traditional territories, and thank you to the Algonquin, Songhees, Esquimalt, and Wasanish people for hosting us here today for our Culminating conference. And of course, a thank you to my family, my support system back home throughout this whole learning journey. And I'd also like to thank all of my peers instructional and non-instructional staff here at the School of Public Health and Social Policy. I couldn't find a picture of you, Nigel, to throw up there, but a special thank you to you. So the public health issue of concern for this pilot is household food insecurity as it relates to poverty and diet-related chronic illness, such as obesity and diabetes. And food insecurity is being defined as the inadequate or insecure access to food due to financial constraints. So in a review examining the literature, examining the link between poverty, obesity, and diet-related chronic illness, Burns said that those with the poorest social, economic, and educational resources are at the highest risk of developing diet-related chronic illness. And this is largely due to the fact that healthy foods are much more costly than processed high-calorie, high-fat, high-sugar foods, which are more readily available, and this is particularly cheaper. And this is particularly true in rural and remote regions, which often lack formal grocery stores. And food insecurity is a significant public health issue, as it is a risk factor for obesity, diabetes, high blood pressure, cancers, and many mental health issues, including depression, anxiety, and even suicide. Food insecure adults are over twice as likely to have diabetes than their food secure counterparts, and food insecurity is a barrier for chronic disease management, especially for those like diabetes that require a strict diet regime. And in another review of healthy eating interventions, poverty was most commonly cited as a barrier to the program's success, because you can tell someone to eat healthy, you can show them how to create a salad, but if they do not have the money to purchase the healthy food, the program will not be successful. So the context for the program is what I would call the west coast of Vancouver Island. It's like a sub-health region of LHA 70, Alberni, Clayoquot. The 9 communities of Hot Springs Cove, Ahousaht, Opitsit, Tofino, Tyastanis, Essoista, Ucluelet, Atatsu, and Makoa. And all these communities land somewhere on the remote to isolated island spectrum that Island Health has for their rural classification. So they're all very rural and remote. Despite that, it's a high tourist area. Just last year, over 1 million visitors were recorded. The area has a startling high cost of living. This is $20.11 is the living wage for the combined costs of living in all those communities, so it's a regional rate. That's the second highest in BC after Vancouver, 10 cents per hour more expensive than living here in Victoria. Highly driven by the high food costs. The cost of eating on the west coast is up to 20% higher than in neighboring Port Alberni, which is around 100 kilometers away. And furthermore, there's only 2 grocery stores, one in Ucluelet, one in Tofino, and those communities that you can see are boat or plane access only, have a high travel added cost of food. Residents from Ahousaht spend $40 to get to the grocery store, and from Hot Springs, $100. And most the majority of residents in the region earn less than a living wage, and 40% earn less than minimum wage. And there's a really high child and youth poverty rate. Nearly 30% of all West Coast children and youth are living in poverty. And obesity and diabetes are both identified as regional concerns in all of the communities. So this is an illustration of the fruit and vegetable prescription program process, which has been adapted by Wholesome Wave organizations. Okay, 5 minutes, thank you. Original program. So food insecure patients and their families will be invited to participate by their family physician. The physicians will prescribe fruit and vegetables to participants and their families. Those prescriptions will be redeemable at a participating food vendors, which ideally will be, there's a local food distribution organization who operates a weekly food markets and food box programs. And then the families will prepare and eat healthy food together and are encouraged to participate in like community-based food literacy programs. And so this is a pilot proposed for 12 weeks in alignment with the local food market. And then hopefully if it's successful, there'll be long-term funding and engagement of the grocery stores as the year-round vendor. I chose to focus on a targeted focus on food insecure like young women and mothers because of the recognition that early environments of childhood development, which include pregnancy and even the preconception environment of the mom, are crucial for long-term health outcomes, specifically around healthy eating, obesity, like healthy eating in utero and early childhood is a big protective factor for healthy eating through adulthood and then preventing the onset of diet-related chronic illness. The design will be regionally, ideally, and then the three main program sites will be, there's 3 health clinics in the region, which then serve all community residents are attached, well, 92%, it's a very high attachment ratio of West Coast residents see a physician at one of those 3 clinics. And then the secondary program site would be the weekly local food markets as well as the box program for those that don't have a food market in their community. At the clinic, the participant will receive $1 per day per person in their household. So a family of 5 would receive $35 a week, which is in line with the food box weekly program costs. And it's also an opportunity to check in with a physician about how the program's going and get some healthy eating counsel and set some goals. There will be an optional like food literacy, healthy eating workshop component, which I'd like to tap into existing programs. 2 minutes, thank you. I wanted them to be optional because I don't want them to be a barrier to participation. I mentioned time poverty earlier in a question. I think that's really true, the more barriers, the more things you have to do to participate as a young mom, I think it just becomes harder and harder. So I was hoping to actually incentivize participation with extra voucher. So these will take place in communities, tapping into what community organizations are already doing and hopefully provide them some consistency to their program offerings and also then be open to the public. These are the broad outcomes that I've identified. I've identified a bunch of short, medium, and long-term outcomes, but these are the 3 that I think they all fall under. And 1 minute, okay, I'll conclude. To conclude, the West Coast prescription program applies a socio-ecological approach to health promotion as it aims to positively influence health outcomes on various levels and in multiple environments of health. Of influence, Although the concept of a fruit and vegetable incentivization program is relatively simple, it's still considered innovative for the healthcare sector. And as it gives physicians a tool to promote, I thought I saw a sign waving, to to promote non-communicable disease prevention within their practice. That being said, several limitations do exist. Physician time. Physicians are notoriously busy people, and to ask them to engage in a project like this, they might think I'm out to lunch. Funding is also an issue, although there's a number of community foundations that fund this type of work. And my time's up. Thank you. Questions?
Thank you for your presentation. That was great. I have a question about whether or not you had considered having a nursing component involved, so either nurse practitioners or the expanded scope nurses who work in nursing stations, or even public health nurses who are so situated within communities, if there was a reason why or why not they weren't, or maybe they are included in some way.
Definitely that's a good question, and I've certainly considered that. What was I thinking? Basically, I think the physician, where we live, there's no nurse practitioners. There's a few nurses doing their remote practice, and then public health nurses aren't as accessible as the physicians are. So although the focus on the first 1,000 days, I think would be well suited for a public health nurse to take the lead. And this program, it's adapted using the model by Wholesome Wave, and you can adapt who the primary care healthcare provider is in running the program. I've just modeled it after the most common one being the physician as a top choice with that high attachment rate. I think it'll be most accessible. We do have a lot of part-time positions due to the funding structure of us being a sub-region within LHA 70, where a lot of those nursing positions you're saying are actually part-time or they're full-time for all 9 communities. They're stretched. So I'm just not as sure about that, but I think that would be the first limitation to address, and I'd be open to what those people would like to do, kind of a thing. Take direction from there. You're being recorded.
I have 2 questions. One, have you been working with the Alberni Valley Food Security Hub at all to try and get those remote regions to have a fruit and vegetable prescription? And also, have you looked into a good source of fats for the developing fetus?
Okay, sure. The first question, it's interesting. The Alberni Community Food Hub is actually a co-food hub with Eat West Coast on the West Coast, of which I used to be the coordinator. So I work more so with the new coordinator of Eat West Coast, and she's looking into a voucher program, like the farmer market voucher program, but I haven't totally pitched this idea yet. And then around the healthy fats for the fetus, just makes me think of salmon, and salmon's such an important food for Nachalnath, and food fish and such. So the feedback I got in my practicum project, this is a separate project from what I did in my practicum PS, and it was interesting in how the nurses' perspectives was the heavy intake of salmon served as a strong protective factor against obesity and diabetes, and that I guess I didn't really relate that to the young mothers aspect of your question, but that's all I've got.
Okay. Oh, there's one. There we go.
Just regarding, so physicians would be providing the prescriptions, is that correct? So what are they looking for? I mean, is it solely based on socioeconomic status of the individual, or on health, like diet-related health issues like obesity and type 2 diabetes? Like, what are the criteria for giving this prescription?
Good question. For this pitch, it's just food insecurity. So there's a food insecurity screening tool. I should have probably had a slide on that, but it's asking around, in the last 3 months, have you ever had to cut back your meal size or that of your kids to make ends meet, or did you miss a day of eating or miss a meal, or do you feel stressed about buying food and stuff? So it'd be answering yes to one of those three questions to be enrolled, unless a physician wanted to adjust the eligibility criteria to specifically target obesity or diabetes, so that we could then measure like A1C levels. So it could be adjusted, but this is just 3/4 of Canadians don't meet the healthy eating requirements. So and then with the biggest vulnerable population being food insecure, so just kept it broad. Yeah.
Okay, thank you. My comment about prescription right at the beginning, there was a physician who was quite famous in the late 60s, early 70s, I forget his name now, who was working in a community health center in Appalachia in the States, and he was prescribing food. He was getting his prescription pad and prescribing food and sending them off to the pharmacy, I guess, or wherever it was to get food. Drove the Medicaid administrators nuts, because you can't do that, doctor, they said. And he said, I'm a doctor. My diagnosis is hunger. The medical treatment for hunger is food. And it was a lovely idea that I think we need to resuscitate. So thank you for helping do that.
Yeah, thanks.
Thank you.
Thanks, everyone.